Hi, test 1, 2, 3. Anyway, this is going to be chapter 5, and pretty much it's roughly from page 49 to 57 of this book, Basic Pharmacology for Nurses. Now, we'll be quick, so typically what we would do in class would be we answer the objectives. So, one by one, after the big rundown, we'll be able to do and understand that. But at the same time, we do have what's called these handouts. There you go, these handouts that we do follow in class. But pretty much, it's going to be like a review. So for those people that are audio, this is going to be good for us. So pretty much, there's 3 domains of learning: cognitive, affective, and psychomotor. Now, cognitive, of course, now it says in the book, this is at least the level at which the basic knowledge is learned and stored. So this is the mental skills. It involves learning and storing knowledge. Now, for the affective domain, it involves feelings, the needs, and the values and the opinion of your patient. So in patient teaching, we have to know their affect, how they look, how they perceive things. So it's really all about connecting with the patients and connect to the patients what they do need to learn, because it's really important. Pretty much that's what we're going to be doing a lot of. Now, the psychomotor domain reminds me of my seatmate Elizabeth. She says this is the doing domain. So it involves the manual and the physical skills pretty much. And I did see in our past ATI questions, it does have a lot of questions that has something to do with readiness to learn. Now, it's a biggie. Now, before doing anything, pretty much what we do is assess their readiness to learn, capacity to learn, and the amount of knowledge that they do have. Now, I'd like to read something. It's in page 49, Clinical Goldmine. I guess it's an introduction and a summary of everything. The development of a sense of trust and confidence in healthcare providers can have a powerful effect on the attitude and the patient's and his or her family members. This can influence the patient's response to the new information that is being taught. The nurse should be positive and accepting, and involve the patient in a discussion to draw out his or her own views regarding the solution to the problem. Why? Because we are going to be patient-centered, right? So we do need their opinions. We do need to know their readiness to learn as well. Now let's go and learn about the principles of learning. Now, pretty much principles of learning. Why do we need to know the principles of learning? It's about the fundamental truth about teaching and learning. It's about the foundation of a certain system. With regards to this, what's the foundation of teaching and learning at the same time? Now, it says here in page 50, patient education is an important nursing responsibility that carries legal implications if there is a failure to provide and document all relevant patient education. Pretty much, you know what? It all depends. Our success and failure would depend on that. I don't know. That didn't sound right to me. But anyway. Now, principles of learning. The focus of learning underneath that. It says that we do have to repeat information to help our patients master the concepts. Now, the environment should also be quiet, well lit. Why so? It has to be conducive for learning. And we have to provide the essential equipment. Well, if you've got a deaf patient, what do? You don't speak loud as usual, right? Oops, that's distracting to me. Anybody that are visual learners, we got to give them some props. And we have to ask for an active participation. Kind of gives you the hint whether they're liking your way of teaching as well. And learning styles, you got to know them. If you do remember, at least know the kind of learning style that you are. kind of learner that you are, but pretty much if you remember their, the visual, the auditory, and the kinesthetic, you have to assess that with your patient as well, because knowing the learning styles will help you create the best response from your patients. Now, it has to fit the teaching techniques to the learning style, and we have to provide a variety of media of learning, such as pamphlets, videos, models, slides, photographs, charts, which apparently we're not supposed to be doing anymore. We have not done in a while, and computer instructions. Now, organization of material to be learned. This is on our part. We have to tell our patient pretty much what they will be learning. So it's not, just not being scattered brains out there. And then we give them time to practice and ask for questions and review what's being taught. So there's what you call the return demo. Literally, like if you're going to teach them how to administer insulin to themselves, definitely return demo. And then there's what we call a teach back in page 51. I believe it's very important. It's a method that refers to asking the patient to explain in his or her own words the instruction she or he just received. And then again, there's the demonstration back. Now, motivation, why is it important? You always want to know whether you're doing good or not, right? So, provide positive feedback when teaching. Determine through the patient outcomes when there is more teaching needed. Just like what we've been seeing in our ATI questions, there's definitely a lot of questions where what's the first thing that we need to do when it comes to patient teaching? And of course, it's going to be assessing what they know first before we start teaching, whatever instructions we need to give them. Now, another thing would be the readiness to learn. Now, readiness to learn, it says there that we have to ensure the basics needs first, because an example there would be, if the patient is in pain, do you think the patient would be ready to learn? No, or hungry. And then, just like what we said, and the first thing is we always have to assess, because it all depends on what the patient already knows. So he'll be more motivated to learn what he doesn't know. And make the content relevant. And the learning pace. That will be on page 53, actually. There's such a thing as the space and content. People actually tend to remember what they learned first. So the learning pace can depend on the style, and it can depend on the age of the patient, and the psychosocial adaptation to illness. And if they're grieving, if they just found out they had cancer, I don't think it's the time to teach them something. And because it's going to show them, it's going to show willingness to learn. Now, if you go to page 53 with regards to lifespan considerations for teaching older adults, it's which I believe there's going to be a lot of in the SNFs. It says here, the older adult needs to be further assessed before the implementation of health teaching. These assessments should include vision, hearing, and short-term or long-term memory, if a task is to be taught. Even their fine motor skills, fine motor abilities, need to be evaluated as well. It's not that they're cognitively impaired. No, it's not that. It's just that they just tend to process things slowly. And we just have to, this is where the pace comes in. We have to give it to them staggered, not in all one big bulk of information. And another major concern would be regarding the cost of the proposed treatments. Not our problem, but we have to know if it is going to be their problem, then we have to go refer them to a social worker or a case manager. Now, that's that area where it says their psychosocial areas, if they're ready. It is also important because at this stage for older people, there's a lot of death going on, so grieving and losses. We do have to take that into consideration. And older adults can learn the material, but they again process things slowly. So just be patient. And with regards to a lot more, there's just other physiological factors that would not really inhibit but delay learning. Now let's go to the meaning of ethnocentrism. That will be on page 54. Ethnocentrism is the assumption that one's culture provides the right way or the best way and the only way to live. Did that sound right? Well, that's on page 54. But as a nurse, apparently a lot of nurses are guilty of this, thinking that their culture would be the best and the only way as basis of what is right and what is wrong. And wrong, that's negative, because we are definitely culture positive or adaptable. Yeah, because we are, again, patient-centered. Now let's go to page 55 with regards to encouraging adherence. It's important because healthcare providers and educators tend to think that a patient should change behaviors and adhere to a new therapeutic regimen simply because the nurse said so. Absolutely not. However, patients do have the right to make their own life choices, as they often do. Absolutely. Autonomy. Don't forget that. Now, positive reinforcement does help patients succeed. They're like little kids. Everybody's like little kids. You got to give them positive reinforcement. Even you want to hear you're doing great. Good job. Now, response and compliance depend on numerous variables like beliefs and perceptions, effects on lifestyle, acceptance and denial of illnesses, and then stress. Oh gosh. And pretty much we're going there. We're nearly on page 57. Why do we need to encourage adherence? Because apparently it's really costly. And then if we do not teach our patient effectively and accurately, it's actually costing the country at least like $300 billion yearly, just for the cost of the patient. So if they don't know what's going on when they get discharged, they get sent home. Oh gosh, what am I going to do with this syringe? Stick it here? No. So if they get it wrong, they go back to the hospital. More money. And actually, it would say down here, strategies to increase adherence. So there's different ways. Challenges to nursing. Just like what I said, poor adherence increases costs and it's unnecessary. And with regards to case management adherence guidelines, they did say there's version 1 in our printout. And there's a tool to help identify those at risk for non-adherence. And I believe it's what you call ethnography. And this is used to observe how patients follow healthcare regimen at home. Because literally what ethnography means, it's the scientific description of the customs of an individual, of peoples and culture. So using those lines for chapter 5, I hope it's pretty much, helping us for the next chapter. I guess the idea for chapter 5 would be the best way to tackle patient education and how to be the effective teaching nurse that we can be out there to get the optimal positive effects for our patients.